Dr. Gray is a board-certified neurologist who completed his neurology training and movement disorder fellowship at Loma Linda University in California. His primary focus in caring for patients and their caregivers affected by Parkinson's disease is counseling and educating them on the symptoms and progression. He emphasizes maximizing their quality of life and their physical function and recognizes that each patient requires a personalized treatment. Like the joke is, if you met one Parkinson's patient, you've met one Parkinson's patient. Along with motor function, he addresses and understands the impact of non-motor symptoms, including mood and cognition and sleep. His holistic approach includes family members in treatment plans. Dr. Gray, we're so happy you're here today.
Thank you. Thank you very much. Should I get started?
Yeah, good to go.
Great. All right, awesome. So 53 people here. That's a lot of people. Thank you all for coming from wherever you guys are coming from, near and far. I'm in Virginia right now, kind of near DC. So yeah, it's pretty cold. I think last night was below zero freezing. So not too bad. I'm from Michigan, so this is kind of what I'm used to, but still kind of a shock to the system. So today I'm going to be talking about kind of a holistic approach, right? This is kind of how I see the practice of medicine and how it should be, right? It's a whole different discussion, but the whole paradigm of what we're living in these days in the healthcare system, and as a patient, as many of you have probably experienced, and as physicians, as we have experienced, there's just been a large change, and focus more on the business aspect of productivity and making as much money as possible, which is important, of course, but if it compromises healthcare for the patient and families, I think that's when it gets a little bit backwards. So this is sort of my approach to the individual instead of a patient, looking at a whole person, not a collection of symptoms. So how did I end up here? So, I always want to be a physician. Why? Well, I just love learning about diseases and wondering and asking questions, but the scientific knowledge is what we all are graded on in school on the way to becoming physicians, but we learn all the nuts and bolts. You have to know when someone has a tremor, what could that be caused by? Is it medications? Is it a tumor? Is it Parkinson's? Is it what have you? But really, the most important thing from a clinician standpoint and from a patient standpoint is being able to have that connection with your doctor or your patient. And even if you don't know the answer, it's okay sometimes. It's okay to not know the treatment, or at least not have the cure, because that's often the case. But the key is to be able to connect with that person or that family member, with the patient, et cetera, because therefore moving forward, you're going to be on the right foot and getting good care. So I'm a DO, and DO is Doctor of Osteopathy. In short, it's just like MDs, they're in every field of medicine. I chose it because they're into more holistic care. So this is why I like taking care of patients with Parkinson's. This is by far my favorite population of patients to take care of. There's just so much you can do. Restoring the function, restoring walking, improving your talking, your mood, your concentration, motivation, energy balance, sleep, eating, independence. I mean, these things can be really tailored to, and a lot of it has to do with the dopamine deficiency that we see in Parkinson's. But it's not just that. It's not just boiled down to one chemical. It's really about the individual approach that we have. And it really starts with listening to the patient and the family member's concerns, and not just looking at a collection of symptoms. So the approach that I try and take and strive for is a completely individualized approach. And every visit gives me an opportunity to improve your life. So what is Parkinson's? And, this is not the first time hearing this for a lot of you in attendance today, but basically it's a progressive condition. Now, progressive, it's scary, right? Because it means it gets worse, but it doesn't mean fast, right? And furthermore, even in the quote unquote advanced cases, for someone who's had it for 20, 30 years, there's always hope. There's always new things that are on the horizon and things that we can adapt with. So there's always something to work with. And, when we diagnose someone, we look at them when they have shaking or stiffness, but that does not take into account the silent killers, the invisible symptoms, the non-motor symptoms, what you see there. that it's in the iceberg part of the water. The anxiety, depression, the sleep changes, the poor attention, the confusion, all these things play probably even a bigger role than we think. So, rigidity, right? Rigidity is something that as physicians we look for as a clue to the diagnosis, right? But patients are going to say it differently. They're not going to say, "Doc, I got rigidity." That would be pretty impressive if they said that. I might want to do a little case report on that. That would be interesting. But no, patients, nothing against you guys. You just don't, you make it a little difficult for us. So we have to ask the questions. So, you might hear, "Oh, I can't stand from a chair without help," or I nearly fall when I turn around," or "I have pain in my shoulder. I was told I may need surgery." You get that stiffness in your shoulder because your arm's not moving much, which is not a joint problem. It's a Parkinson's problem. Or you must have a lot of cramping, or I can't roll over in bed. These are all things that manifest themselves because of rigidity. Now, bradykinesia, on the other hand, is another important thing that we see and that you guys, live with. Patients may say, "My father has a lot of shuffling and takes small steps," or "I always carry my handkerchief because I drool," or "I don't use button-ups anymore. Just difficulty with, my fingers, coordination and whatnot, and I can't keep up with my family when we go out." So a lot of these things, these are real statements that show how impactful these symptoms can be. Not just symptoms, but they're actually things that really truly impact someone's life. And so, in a nutshell, in a very general way, our rudimentary understanding of this condition, we know a lot, but by knowing a lot, we realize how much more we need to know. Um, Dopamine in the form of, for example, carbidopa, levodopa, or Sinemet, which is one of the main medications, that will replacing that by taking the medication will significantly improve your rigidity and bradykinesia. Significantly, as far as compared to other types of symptoms you may have. But you know what? There's more than just medications, and this is where I really go into the details. Medications are one thing. We're great at prescribing medications. That's what we do. We get a degree and we learn about all these things. And we can figure out what the right medication, the dose, the frequency is. But it's really more than that, right? Because medications are what you take, what you ingest, which is important. But you're doing things every single day. You're moving, you're breathing, you're eating, you're interacting. So things that work on your ability to function, right? Get up, get out of bed, become motivated. Those things are just as important. And in order for you to live a full life, we want you to be independent. So physical therapy, occupational therapy, speech therapy, exercise, all these things are necessary and even required, frankly, just as much as medications. And certainly, any side effects that you may have within medications, even some that are very subtle, need to be discussed as well and mentioned to the doctor. So what stage are you in? I get this a lot. All right, so I have this, now what? How much longer do I have? And frankly, the real answer is I don't know. And that's how it should be. That's how every doctor should answer it. Or at least maybe not that direct, but they should at least say, like, "I'm just not sure. We don't have the answer," because that's the truth. We don't have the answer. We don't have the answer. I mean, it doesn't matter if someone comes in with a tremor on the right side, or if they come in, they have no tremor and they have stiffness in their trunk. It really does not tell us, say, where you're going to be in 5 years, because there's so many things that are influential in your disease state. But there's always something we can do for help, whether you're tiny little tremor in your finger or you're in a wheelchair and you're stiff as a board. There's always things we can do to help. All right, so this is just a very, very brief. I just put this in there just to kind of show that a lot of the disease is silent. So in the middle, between the white and the gray there, which says 0 at the bottom by diagnosis, that's when we actually see the symptoms. You actually notice the tremors, the stiffness, the slowness, right? That's when we notice, oh, I can see that your arm's not swinging very much, right? And you notice it. You might not notice for even longer than other people. So, but years before, we do know that the process is probably happening long before it, and it's affecting other systems. Some patients may have decreased sense of smell. Well, that's actually because there's the abnormal proteins that we can see in the brain of a Parkinson's patient, are actually seen in the areas of the brain that allow you to smell. Same with regulating your gastric motility, constipation. Same with regulating the tone of your muscles when you're dreaming. When you're dreaming, we should not be moving. We should be dreaming and just, having it in our head, not actually in our body. So that's where patients will have something called REM behavioral sleep disorder, where they'll move a lot, they'll shake a lot, they'll kick, they'll scream, they're acting out their dreams, as we say. But that's actually in a process that's seen in Parkinson's in some instances. So that happens before. That's on the left side of the graph. The right side of the graph is, as time goes on, these things can get more and more problematic. So this is a really important slide. I tend to try to show this sort of a diagram in some shape or form to patients when I first see them and talk about the medication, because it's as important for us to understand this as you guys, because you guys are living this, right? So in the white, so the line going back and forth, the peaks and the troughs, that's the level of dopamine in your blood. Okay, so you take a medication and the level are going to go up because your body is taking in the medication into the blood and the brain, and we can measure that. If we needed to measure that, we can measure that. And then eventually your body's going to break it down because it breaks down things that are there, and it'll process them. And so in the white area, that means that you're good. You have no symptoms. You're pretty much normal. And that's what we want. That's really what we want. But over time, the window of feeling good will kind of get smaller and smaller. What do I mean by that? So if you look at sort of the latter part of the graph on the right side, you see that the pink and the gray are getting closer and closer to the white part. So the pink is the excessive movements. That means that there's relatively too much dopamine. Okay. The gray is the paucity or the lack of movements. Okay. So it's being on, which is being white, or being in the white area or in the pink area, meaning you have enough or too much movement, and you have the off, which is the gray area. Okay. So every single individual will be different. What we expect as doctors is, when I feel my medication wearing off about 30 minutes before my next dose, I feel that I get stiff, or I feel like I get anxious, or I just feel restless. But everyone has different manifestation of that. But I always teach patients, you need to figure out how you can tell if and when you feel like you're running out of fuel. You feel like the oil needs to be changed in your car, because I can't tell. I can only see what you're saying, and I can ask questions, but some things can be so subtle and not even apparent, even sometimes to the patient. But that's where the education comes in. So this is very, very important to know, being on and off. And when you're on and off and on and off, those are called motor fluctuations, and that's when some people think the carve it up, love it up, it's just not working anymore. The body gets used to it. That's actually false. It doesn't. Because as you can see, on the left of the graph, it's day zero. On the right of the graph, it's over 10 years. This is obviously just, artificial graph. But basically, the level in your blood is going to be the same. It's going to go up and down, up and down. But so therefore, it's not that the medication is not working. It's still in the system. You just need more of it. You need more tight control. So that's when a lot of different therapies can be employed to help continue to improve your life. So again, the goal is to have more on and less off. Okay. So my goal is to target the motor fluctuations. So we need to figure out what they are and to get more on and less off. And there's a lot of different medications you can use. And then your goal is to know you're off and tell your specialist when you aren't on. Okay. So we can improve your quality of life there. So again, before we talked about other invisible symptoms. So these symptoms could be apparent when you're feeling off. Okay. So anxious, depressed, irritable, fatigued. You might have the urge to urinate, sweating, body pain, brain fog, dizziness. All these things could be actually improved, and sometimes improved with medication. So then you know that is a symptom of your body running out of dopamine. So what we're taught in medicine, and this is again a generalization. This is not a condemnation of doctors, but this is just kind of from my perspective, what we're taught in medicine. So we're taught to look for disease, right? We're taught to connect the symptoms that the patient may have to a specific syndrome or condition, and then we're trying to get the diagnosis. We're doing lab tests, X-rays, ultrasounds, MRIs, CTs, etc. And then we prescribe the medication, right? Because symptoms need medication, and then we treat it. That's the ideal. So the patient will say, yeah, my symptoms are caused by Parkinson's. I need medications for them. I need to keep seeing the doctor and keep taking medications. I'm told I will get better with physical therapy. I'm told I need to eat healthy and exercise. But how do I know if I'm doing really good? Well, they say I'm doing good when I see them for 15 minutes, right? That's sort of the unfortunate reality in our day and age. I don't think it's the desire of the doctor to be that quick on patients. It's just sort of the product of our times. So, for example, if we have a 44-year-old patient here, male patient with tremors, he's very active. He doesn't take any medications, but he's noticed that his right arm is not moving much when he walks. Okay, so when it's all said and done, the doctor may say, you got Parkinson's. Here's a medication. Come back in 3 months. Okay, well, a lot of things. One, I want to know. Tell me about yourself. What do you do for work? What do you do for fun? How does tremor affect your activities? What do you or your family notice? What worries you the most? So, I mean, this tremor is what I see. It's a symptom. I can treat it. But do I need to treat the tremor? Is that something that is even a priority, right? He might have come to see me at the behest of his friend or family member or doctor, but he's like, well, I mean, I was told to come here, but he's not doesn't want to be. This is not something that he wants to talk about right now for whatever reason. Maybe it just doesn't bother him, but he doesn't want to talk about it because he's bothered by it. So as a doctor, I always try to gauge this scenario. Like, if you're not worried about it, I'm not worried about it. Meaning, I don't want to make your life any more miserable or I don't want to make your life bad or miserable at all. I want you to live and understand that you can live a great life, however or whatever you're like. So I always kind of gauge the scenario, get to know the patient as a person first. So counseling, treatment may or may not be needed, frankly. And again, this patient is with me for a matter of 30 minutes to an hour, right? And so I want to educate them about it. I want to educate them the treatment that's out there, therapy, and things they can do for himself. Because most of his life he's not going to be with me. He's going to be living on his own in his work and his job and his home. So my goal for all patients, by the time they come in and leave, is for all the questions regarding this condition to be addressed. Because unfortunately, a lot of patients will come in. They might have been diagnosed with Parkinson's in another clinic, or they might have received a different diagnosis. They do have Parkinson's, or vice versa, and they clearly, it just doesn't sound like the doctor had discussed it to them very much, or even made sure they're aware. So my goal is to empower the patient so that they can understand what's going on moving forward. Another here is, 88-year-old female, difficulty walking. So she was diagnosed with Parkinson's 5 years ago. She's wheelchair bound and she needs assistance standing up. She's incontinent to urine, and she smells insects crawling around at night. Okay, so basically she's got difficulty walking. She has accidents and she hallucinates. Okay, so what we do is we say, oh, you got incontinence? Here's a medication. You need you need difficulty sleeping? Here's a medication. And you need hallucinations? Here's a medication. You got Parkinson's? Here's a medication. Okay, well, again, this is just taking those tidbits of information we hear, hallucinations, incontinence, difficulty sleeping, and let's just treat that. And that is a very simplistic way of going about it. That's a very quick way of doing it, but it's a very, in my opinion, does not suffice. It does not suffice to really remedy the scenario. So again, I might ask, when was the last time you were walking independently? Is this something that 5 years ago diagnosed, but then a week ago you stopped walking because why? Because you broke your foot, because you had a stroke. I mean, versus, oh no, I mean, 10 years ago I couldn't walk independently, and then 5 years ago I had Parkinson's. Okay, that's different. That just gives me a different perspective of how fast this may be going. How active were you before the symptoms? Are you in pain? Who takes care of you? What are some expectations you have? And what are your most bothersome symptoms? So again, medications may not be the most important factors. How can I improve the quality of life? And what's the most important thing to the patient, Because everything does not need a medication necessarily, right? More medications, potentially more side effects, potentially more drug-drug interactions. Not to say medications are not good, they are, but they're only part of the story. So just some vitals for life, things that we all need: physical activity, sleep, and nutrition. So exercise can slow progression. It really does. It just had that effect. Increases the natural dopamine levels in the brain. There's neuroplasticity that continues to happen even as we age. So don't let anyone ever say, as you get older, your brain shrinks. Well, that's sort of, we hear about that all the time, and we see CAT scans and MRIs. Oh, my brain's smaller, or you might see I have atrophy. So, well, that's sort of, we're kind of making it a foregone conclusion if we just accept that the brain shrinks as we get older. We're supposed to have forgetfulness. No, in my opinion, that should not be something you know, we stand on, because therefore we're sort of setting ourselves up for failure. We're telling each other that that's just how it's supposed to be, but there's a better way to do things. Big therapy. Many of you probably heard about this. Is the type of therapy that's specifically tailored for treatment for patients with Parkinson's, that improves movements, improves hesitation, improves the slowness, and increases the amplitude of movements that patients don't have much of when they have Parkinson's. But even just doing this alone without changing medications can improve both your motor symptoms and your non-motor symptoms. Well, how is that? You're not giving medications, but you're stimulating that dopamine, which is inside. Sleep. So sleep, different things that can impact your sleep. Insomnia, you can wake up in the morning early, difficulty falling back to sleep, urinating frequently, stiff or tremors, or you might have those dreams I talked about, violent dreams, anxiety, depression, lots of things. So, and then one thing we see a lot is, we call excessive daytime sleepiness, meaning during the daytime, you're falling asleep on the sofa, you don't feel like getting out of bed. You're in the middle of a conversation. Your family member's like, hey, wake up. All these things can be a problem, and there can be a lot of causes. Of course, if you're not having good quality sleep, then it's like you're not sleeping. Mood changes. You're not feeling motivated to do much. That could be something. The environment. If the environment's not really much going on there, then that could be something too. And then just not being stimulated, not having the activity to do things, and the medications can also potentially cause sleepiness. Sleep apnea is very common, both in and outside of Parkinson's. This is one thing I almost always talk about, or at least screen for, because this is something that, as you can see on the right, the diagram there, on the right side of the diagram, the right column, this is the prevalence of sleep apnea, and all those conditions there show that, for example, 73% of patients with Alzheimer's have sleep apnea. So that's just sort of, in some studies, they probably came up with that. I mean, it just shows how prevalent it is. And there is a direct correlation between sleep apnea, or poor quality sleep, and a lot of chronic diseases: diabetes, high blood pressure, obesity, um, high blood, I should say, stroke, heart attack, all these things. So it behooves us to look for this and try and treat it if it's there. Risk factors, sinus or nasal septum defects, large tongue, posterior jaw. Any alcohol, tobacco, or sedatives will make that more likely. If you sleep on your back, if you're obese, if you have a thick neck, all these things, right? And this is another screening tool we use on the right. Treatment, weight loss. The CPAP is what you see pictured here. This is just kind of give you guys an an idea of what's out there. Insomnia, another huge thing in Parkinson's as well as the general population. So sleep hygiene. There's a program called Cognitive Behavioral Therapy Insomnia. It's the first line recommended therapy treatment, I should say, by the American Academy of Sleep Medicine. So it looks on the whole behavior, because we can change the way we, our sleep cycle and our day-to-day routines, then we can probably fix, most things with regards to sleep problems. So, for example, caffeine in the afternoon, you can try to cut that down. Cut out alcohol in the evening time or altogether. If it's too loud, too bright, it's going to be hard to relax. If you're up in bed, if you're still awake after 20 minutes, you should get out of bed, because you're going to subconsciously associate being awake with lying in bed and looking at the ceiling. So those are things to really keep in mind, and make sure you try and get natural light, ideally outside, for 10 to 15 minutes every day. That's something that's going to help your circadian rhythm. Restless leg syndrome, many of you have heard of this, maybe you even have it. It's just this inner urge to move that feels better when you're actually moving. And it happens usually initially at nighttime when you're sleeping, or I should say when you're laying down. So these are other things other than medications, because of course we have those. Maintaining healthy sleep hygiene, massage, exercise, taking hot baths, kind of pressure socks. These sorts of things can help alleviate some of these symptoms, even before considering medication. REM, behavioral sleep disorder. This is the thing I talked about before with the violent dreams. Things that there are medications like melatonin, but things that you can put up as precautionary measures, or bed rails. You can make sure fragile objects, etc., are not nearby, and make sure obviously that the bed partner knows this, because they also can get injured, unfortunately. Nutrition. So nutrition, this is again the kind of the tip of the iceberg. I mean, this is a topic in itself, of course, but plants, we always want to supplement ourselves with all these vitamins and minerals, but all those come from plants. Plants, fruits, vegetables, nuts, seeds, all of them come from there. So there was a study that it did actually improve Parkinson's symptoms. Again, this is a small study. We don't have much data on it, but it just shows that fiber is a big component. These are some foods that you can find fiber in. You have raspberries, avocados, oatmeal, and flax seeds there. So all these things that you can add in to improve your diet and lifestyle. So, and then some of you may have heard this. Don't take the medication with food, or avoid protein. And there is a basis for that. Carbidopa, levodopa, it is actually an amino acid, which is a part of a protein. So protein as well can compete with it. So therefore, if you eat a high protein meal and you take the medication, carbidopa, levodopa, you might notice, maybe not initially, but you might notice later on that you might have more unexpected off time, or the medication just not getting in your system as quickly as you think it would be. So another thing that's interesting, again, just put this out there because I think it's kind of related to the nutrition part of it. They have done some small studies where they take a few patients, 15 or 16 or so patients, and they have them eat the protein that they normally eat, but they space it out and push it back later in the evening. The idea is that you're going to be having less interactions with that medication of the food during the day when you're awake and moving around and doing things, being active, as opposed to when you're sleeping, which, being off, if you're off when you're sleeping is not as big of a deal because you're sleeping. So there are some studies, and this is kind of interesting. I think this should be something to kind of pay more attention to, because again, this is something that can be get to be patient specific toward the individual and not not without having to really change medications. Here's just a food pyramid of some healthy foods that you can incorporate in your diet. This is a really good book that I encourage patients to read who are interested in nutrition. This is a interesting website, nutritionfacts.org, by this physician, Dr. Michael Greger. I personally like him a lot on his content that he has. Really good TED Talk. And then he does have videos on Parkinson's disease, and that's kind of where I got some of the information about the fiber and the protein. So just a few things here. Patients may say, I feel like I'm going to pass out, and so, that's a symptom, but what's going on? Well, it could be something called orthostatic hypotension, which is where your blood pressure will drop lower than it should when you're standing upright, right? And so things you can do without resorting to medications. You can hydrate more, stand up more slowly, wear compression stockings. If it gets really bad, you can do an abdominal binder and avoiding large meals because that can drop your blood pressure. And yeah, medications can play a big role in that. So that's just something to keep in mind, especially as we get older. Urgency, urinary incontinence urgency, make sure that fluid intake is looked at. Caffeine, alcohol can increase your urinary output. Schedule bathroom breaks so that you're less likely to actually go overnight if you kind of have a schedule where you go right before you go to bed, etc. And then certainly urologists can definitely play a role. Drooling, he always has to clean his shirt off. So drooling is something that is very common, and the reason is not because there's excessive production. It's the lack of frequent swallowing because of the slow movements, the bradykinesia. So that's why things like Botox injections into the salivary glands, for example. It sounds kind of extreme, but it's a really effective therapy, and it takes about less than a minute to do. But there's other medications too. There's even just old-fashioned chewing gum or candy that also helps too. So constipation, extremely common in general public, but especially in Parkinson's. So certainly stool softeners, laxative, Miralax, Colace, Docusate, all these things. The one thing that is interesting is this rancher recipe, which is very, very, it's natural. It's only natural. But I found anecdotally that it's very helpful for patients. So you can just look that up there, oatmeal, applesauce, and prune juice, and just take a few tablespoons every morning. And then, when it gets more problematic is, when there's patients over time may develop hallucinations, delusions, and sometimes they may not even realize it's the case. So of course there's medications out there that we have. We always have medication for everything, but redirecting the patient, try not to argue with them, because that is the reality. They see someone there, if and when it gets to the point that they don't realize that that person's not real, then that's where you're going to have, disagreements between you and, say, your mother who has Parkinson's, because she's going to swear that there was a man standing at the window there, but there wasn't. So just trying to let them calm down, make them just feel safe. That's much better than trying to, bluntly disagree with them, even though that's what you should do. At this point in their condition, they're probably not very rational or having the cognitive wherewithal to be able to understand that. So again, depression, apathy, dementia, all these things are important to keep in mind. Crossword puzzles, Sudoku, all these things they're helpful, but you really need to get out and interact with other people and be amongst others in public, and it's tolerated. Play an instrument, do a language, do something that's novel that really challenges your brain. So, and caregivers, right? Caregivers are huge. You guys are the lifeblood for the patients, especially as they get older and more impaired, perhaps. All these things are important, especially to take care of yourselves. You can't take care of someone else if you can't take care of yourself. And we don't want any caregiver burnout. So that's something that's really important to look into too. And again, this is something that I don't think is talked about enough, but it's just important to plan ahead. Don't do it at the very last minute when someone's in their last few days of life. Do it way in advance. It's hard to talk about, but it's gonna happen. We're all gonna one day pass, but the goal is to do it in a way that is um, is planned out, and that there's not significant disagreements, and the patient, most importantly, the patient has their wishes respected, patient and or the family. Because when I worked in the hospital, what I hate seeing is these patients with, very sick patients with a lot of underlying medical conditions that they're dealing with and disability. They come in because they have a heart attack, for example, and of course we're always trying to save lives in medicine, but at what expense? Because when we start doing CPR to someone who's already can't walk, and they're already, not talking for some reason, and you start doing CPR on their chest, well, you're gonna save their life in that moment, but the after effects are perhaps even more devastating. So again, just something to think about. In general, just good for everyone, even for me to even know this for myself, because you never know when. But again, good planning is better than being reactive at the end of life. And that's everything. These are my clinics here in Northern Virginia. I work here in private practice, and if you guys are around, then feel free to give us a call.
Thank you so much, Dr. Gray. So I do want to start off with a few questions. One thing is that you seem kind of prepared to extrapolate the information from people. Like I want to treat the person, not just the disease. So you have questions, but what are some things you might suggest to people to bring up if they don't have someone who is as forthcoming, for example, or is asking the questions? Because, like, one of the things you mentioned when you were talking about that one case study is she couldn't walk beforehand. Like she wasn't walking pre-Parkinson's. And so I always think when you said that, I was sort of like, if my husband were to report sleep issues, well, he's had those for years. So it wouldn't be just because, maybe if he had a diagnosis. What are some things you would want people to kind of say in case if you're not asking those questions, if well, it'd be great if everyone could see me, but not everyone's in Virginia. So what could
Yeah, it's I guess trying to figure out how to answer the question. I guess just your question sort of how to make sure that the doctor addresses what's important to them without the doctor having known what to ask. Is that kind of what you're saying?
Yes.
I mean, certainly kind of like the title of this presentation, it's all about the individual, right? So it really depends on what's impactful for you. So what I would say is, when you come in and let's say you have a new diagnosis of Parkinson's you were just given, well, I think you should bring up whatever it is bothers you the most, right? And of course, you're not going to be able to control what a doctor thinks or says because he or she is doing their job, et cetera. My only hope is that they do take a pause and listen to you more than just the symptoms, et cetera. And of course, there's great doctors out there, but again, it's just sort of how our system is, unfortunately, I think, in the time. But I think just make sure that even if it just doesn't seem related, I would just bring it up because it matters to you, and that's what matters the most. We might see something on the exam, though. Do you really need to get checked out? We're going to treat this medication, get an MRI. Okay, the doctor knows something that you don't because that's their training, but you're the one who's living your life. So I think by advocating for yourself or a family member, if there's something that needs to be addressed, but the doctor's not pinpointing that, then I think that's something where you need to continue to bring that up to the doctor.
What do you suggest? Like, it was actually very interesting to me when you were kind of talking about those signs of like rigidity or bradykinesia, because I've had in support groups, people are often like, is this Parkinson's? I'm experiencing this symptom. Is everyone else experiencing this? Is this Parkinson's? And I feel like one thing people often get kind of caught up with is before they're diagnosed, it's like, you can't have Parkinson's. You're just getting old. You're just slowing down, whatever. And then once you have the diagnosis, then it's like, oh, that's your Parkinson's. That's your Parkinson's. And sometimes it's like, you can have comorbidities. You can have other things going on. What are some things you would say I expect to see versus if you tell me you have shortness of breath, I would say you need to go see a pulmonologist. Like what are some things you're like, yes, I expect to see? Like I was kind of surprised about the shoulder pain, and it was like, that's rigidity. That's not necessarily, like
Yeah.
I would think, oh, orthopedic maybe or something. What are
Right.
some, especially that people might not expect?
Again, very good question. Especially good to think of, because we don't always want to assume what a symptom is related to, chest pain, heart, definitely heart attack. I mean, surely you don't want to miss that, of course. Even if you get one patient out of 1,000, you send to the ER. Well, great, you save that patient's life. On the other hand, the 999 patients are really pissed because it's just due to a muscle pain or whatever. But it's a really complicated thing, and that's why, as an aside, I've gotten a lot of patients who come in with a diagnosis of Parkinson's, and they don't have Parkinson's, and I wasn't in the room with them when they were diagnosed, but to me, it's incredulous just because of my training is different, because I went through training. I would not be adept at diagnosing lung conditions like a pulmonologist, but I think it's important. Again, this is sort of as an aside, for doctors to stay in their lane as much as possible, or at least know when they don't know. Right? I'm happily able to admit I'm not sure. I have no idea if that's due to a lung condition. Maybe you should get checked out. But the fine line is figuring out, okay, I'm not really sure, but you know what? It's possible this could be Parkinson's, for example. But it's a really tricky question because we all might have aches and pains and symptoms, and it's easy to tie it to something. Oh, this is because of this or that. Or, okay, I have this is my shoulder. I have Parkinson's. So then everything you have is Parkinson's. So it's kind of like, it's just how we experience things, right? And that's where it takes an astute physician or someone that really, really, really pays attention, like neurologists do, to figure out if this is really related. So it's very difficult. It's very difficult. Sometimes even doctors don't know. So it's just something that is the way it is.
I have a couple of questions. Somebody asked about because several people commented, because you talked about constipation, but what about bloating? Even with small portions, still bloating. And another person said, like, I'm basically an invalid due to stomach issues. What are some things that could be done to kind of help with bloating, help with stomach issues? You obviously talked about the constipation, and you gave a recipe even.
Yeah. Yeah. So bloating in general, I mean, possibly multifactorial. It could be because there's too much gas. There's a lot of backup constipation that kind of comes up into the upper part of the GI system. It could be that there's, reflux, dyspepsia, it could be that the GI tract is not moving as quickly as it should, right? And so we know in Parkinson's that it's not just the brain and spinal cord, meaning the central nervous system, but there's also these proteins that we see in patients with Parkinson's are also found inside of the nerves and outside of the central nervous system in the GI tract. There's more neurons in the GI tract than there are in the brain and spinal cord combined. It's called the enteric nervous system. So there's so much we don't know, unfortunately, about why things are the way they are. For bloating, Again, a symptom alone, I can think of 1,000 things to say or do, but it also kind of depends on the context, right? So just throwing things out there, smaller meals, more frequent meals, maybe less fatty foods, maybe more fiber, but maybe if you're not used to it, more fiber might cause more bloating because you have gas production from certain bacteria that digest the indigestible starches. That's fiber. Um, Making sure physically active, you're moving, because if you're not moving as much, your GI tract's not going to be as frequently cycling as either. So, for example, exercise can improve constipation. Um, being sedentary is less likely to have more frequent being as frequent. So, just a general collection of thoughts I had about that without knowing the exact case.
Again, people talk about this a lot, doctors talking to each other. Someone asked, are we moving toward a more palliative care approach that keeps everyone in the loop? Because there are so many specialists on so many portals, but they don't have the common access. And obviously, as we talked earlier, most people with Parkinson's do have additional health concerns. And so then it's concerning for a person with Parkinson's that some of the medications or treatments might be contraindicated. Um, you know, is there something also to just, if it's not just in a portal, keeping your doctors in the loop? Do other doctors kind of talk to each other to kind of say, hey, that one medication not as good when they have diabetes, for example? I mean,
Yeah,
how does
yeah,
that work? Because it's the patient, you're just in the middle.
yeah, yeah. That's it does put the onus on the patient, to be honest, because in our system, one doctor's in this hospital system and that doesn't talk to that hospital system. It's like one across the records. We have to do it the old, fax way, which is kind of outdated, but it is what it is. These electronic medical records don't talk to each other, and I think it's kind of a business thing that happens with that. It's sort of privacy is important, of course, but when you have things where patients goes to different specialists and then sees their primary care doctor, and there's a lot of there's not enough talk between the specialists, so therefore patients come in and saying, did you get my records? I said, no, I'm sorry, we didn't get it, and then there's some kind of hiccup along the way. So what I do is, for example, in our system here, small private practice, is, we have, I don't know what it looks like, but when I'm done with the notes, I'll send it to the primary care doctor that's in the file under for that, the patient's name. And I see the note it prepares for the doctor. It says, hello, blah, 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 and then I'll write the note that I write in is in there. And so I don't know if they read it or not, because doctors also get a lot of stuff they have to go through. And a lot of it's like, okay, fine, my staff member can take care of it. But usually what I'll do if I'm like, I want you to either really need to talk to the doctor, in some cases I'll call them, meaning it's urgent enough to bother them now, right? Or here's this information, take this to the doctor and tell them that, ask if it's okay to take this medication, because I don't want to step on anyone else's shoes either. So it's difficult. It's very difficult. The easiest thing to say, well, we all now are on the same page. We all know this medication is prescribed, and then all the specialists are going to be okay with it, or they can at least chime in. But the reality is that's just unfortunately not the case. It's kind of an inefficient system, very fractured system. So unfortunately, there's no uniform way to do this.
I appreciate your honesty that you're not like, no, we talk, don't worry at all. You're like, no, I'm going to be honest with you.
No, yeah, we don't.
You do want to be prepared and be aware that this can happen and things can be contraindicated, and maybe I don't know what someone else is doing if you don't tell me.
Right. Exactly.
Yeah, transparency is good. You had kind of talked about, again, the idea of, okay, so then you would get a pill for this, or you would get a pill for that, and you would get a pill for that. But, we really want to look at everything. But how would someone know if they are over medicated?
Well, another nuanced answer. So I guess we can talk about the most common medication, carbidopa, levodopa, or Sinemet. So over medicated. So one thing is excessive movements, right? Dyskinesias, kind of not being able to sit still, kind of always like this, right? Um, you might have significant difficulty sleeping with that medication, or I should say, significant sleepiness with that medication. Um, you might feel like a surge of energy with the medication. Um, some patients can have like manic like symptoms. They'll go on big shopping sprees. And I have a patient, it's sad, but I think he's in his 80s, maybe. Um, really nice guy. He's had Parkinson's for, I think, at least 15 years, still mobile, still walking, etc. And his daughter comes with them, and he lives in a senior living facility, independent living facility, and his daughter brought it to me a couple times. We're trying to figure out what do we do here, right? Um, a couple times that he's been going by himself to see a woman who apparently is married with someone, but he's been giving her money, and I can't do anything about it. I mean, what I've been doing is I've been reducing the medication, the dopamine medication, because that can kind of stir the pot more. So that's what I'm doing, and obviously um, I don't directly confront him about it because the daughter's telling me with her experience with that. So I don't want to create a negative interaction with the patient. I want to keep it therapeutic with him, but that's something that it can be seen as well, because dopamine it's kind of the dopamine rush, right? If patients get on too much of it, too fast for whatever reason, they're on a lot of pills per day. They only need to be on half of it or a quarter of it or none of it. Then it'll be very hard to get off of it. So just being on this sort of addictive like thing they can have. It's not addictive like addictive medication per se, but it's just the way it works in the brain. It has that effect. So over medicated is anything that's too much, right? So if you're having too much of anything, too much that you're unexpected to have, you're gonna think, is this the medication? Because before I wasn't on this dose, before I was on it, I was not like this. So therefore, you got to ask, and it's always good to ask the doctor if this might be the cause.
Kind of talked about sleeping and sleep apnea. What about if someone just the energy loss? That it's not so much the problem sleeping, it's almost like they're sleeping too much and then they don't have the energy during the day.
Yeah. So first off, I mean, yeah, people say I'm not sleepy, I'm just fatigued, and I go to bed at 10 and wake up at 7, so I get 10 hours of sleep or 9 hours of sleep. Okay, well, um, as a doctor, of course, the patient knows their body the best. But as a doctor, I'm still going to kind of put the sleep in the back of my mind, because the body symptoms are how they are, and they're not going to be as obvious as what the problem is when you say it. The fatigue, can be a manifestation of a lot of things. The fatigue could be lack of sufficient medication, the dopamine. It could be a mood thing. It could be I'm just throwing this out, a boredom thing. It could be maybe you don't like what you do for a job. I mean, it's very difficult without knowing the specific context, But if sleep is good, meaning you go to bed and wake up around the same time every day, you have no obvious reason to have difficulty sleeping, you've had no problems in your life and hasn't changed, but you're starting to become fatigued, another thing to look at is, have you had your routine blood work done with your doctor? There could be some electrolyte changes that could be happening there. So things that are not just mental, emotional things around you and your environment, but also actual things going on in your brain or body that could be causing that too. So just good to kind of rule out what else could be there that could be looked for by a doctor.
We are almost out of time today. So I think thank you so much. Amanda did just put in the chat, and I was going to reiterate for those of you who came a little bit late. I do want to stress that moving forward, You will be getting a survey, but we are starting to cut back on our emails. We're told we communicate and email a little bit too much. So we're going to stop sending the day of emails. All programs will be offered in the weekly roundup that comes out on Sunday. And that's how you would register, as opposed to getting day of emails. We're really trying to respect that people say you email me a lot. So starting on February 1st, we're going to be stopping those. We just want to let you know so you can prepare and really pay attention to your weekly roundups. Thank you so much, Dr. Gray, for taking the time to speak with us today. This was so informative. And I did appreciate your candor, that you were just like, I'll tell you the truth. I appreciate that, because I think a lot of times people don't, and it's refreshing.
Yeah, thank you so much for having me. I really enjoyed it. Hope you guys also got a good experience as well, everyone online.
Always at PMD Alliance, we have a tradition. We have our wave of gratitude. Thank you so much for doing this today, and have a wonderful afternoon, everybody.
Okay. Bye-bye. Thank you so much. Take care.